the psychological trauma of a brain injury, sort of there's the neurological impact, but then there's this idea of this thing that happened to me and your identity changes and sort of how you make sense of the problems you're having now as opposed to before, and is there continuity of you as a person from before and after. These dynamic situations, these sort of dynamic factors are very important and often are overlooked in people with neurological injury.
Welcome. I'm Dr. Charlie Marmer, Chair of the Department of Psychiatry at NYU Grossman School of Medicine. I am delighted today to be in conversation with Dr. Lindsey Gurin. Dr. Gurin is an assistant professor in the Department of Psychiatry, Neurology, and Rehab Medicine, and a deep expert in both neurological aspects of psychiatric illness and psychiatric aspects of neurological illness. And we're very proud to say she is our director of one of America's few combined residency programs, the Double Board Psychiatry Neurology Program, which aims to train psychiatrists and neurologists to be able to work at the interface of those disciplines with the most complex patients. Welcome, Lindsey. It's great to speak with you.
Thank you so much. It's a pleasure to be here.
What is the Double Board Psychiatry Neurology Program?
Yeah, so as you said, there are not many of these programs. NYU has one of 4 in the country, and this is a 6-year combined residency in psychiatry and neurology. So residents are trained to be board certified in both psychiatry and neurology. We shortened the training period. Instead of doing 2 4-year residencies back to back, you do it all in 6. You're qualified to practice as a psychiatrist or neurologist, but we train our residents to practice as combined neuropsychiatrists to see, as you said, these very complex patients who have symptoms that they overlap.
So what I was used to from my training at the University of Toronto, I'm originally Canadian, was that we have psychiatry courses for neurologists, we have neurology courses for psychiatrists, and we try to do our best. But this is a much deeper solution, which is actually to have one person have all of the deep knowledge of both disciplines. And at the interface of psychiatry and neurology, which of the very challenging patients that we care for in our psychiatric practice do you think are most relevant for the double-boarded neurologist psychiatrist to care for?
So there are, of course, a lot of patients who fall into that category. And we think about people with neurological problems. Many of them have psychiatric issues that come with that. And neurologists are not frequently comfortable with managing those problems. Patients come to see psychiatrists who are sort of not, necessarily familiar with the neurological problem. So it gets complicated. The way I got interested in this area was in medical school. I worked at a traumatic brain injury clinic at the Veterans Administration Hospital and saw patients who had overlapping symptoms of traumatic brain injury and post-traumatic stress disorder. This is a clinic for people who were coming back from Iraq and Afghanistan at that time. And it was difficult to distinguish them. And the clinic basically took the position of these are not distinguishable, these symptoms overlap, and you need sort of a combined approach to treat them.
You and I have a deep shared interest in the care of veterans with PTSD and TBI, and it's wonderful that was what inspired you. In a previous lifetime, I was chief at a big VA hospital in San Francisco before I was recruited to be chair here and got very deeply interested in that problem. One of the things I was interested in as I was writing about the history of this in military psychiatry was the idea of shell shock and how shell shock was described in World War I. Is shell shock a psychologically shocking, traumatic experience in that sense, or is it actually the product of the physical wave of an exploding shell causing actual direct neural injury? What are your thoughts about that kind of ambiguous term, shell shock?
Yeah, it's a great question. And I think, what you're talking about is a particular type of traumatic brain injury, blast injury, which is, particular to the military populations. But, sort of we can see this sometimes in other populations as well, civilians who have different kinds of injuries. But this idea of sort of, being that kind of I think a dissociative state, essentially, that probably is both psychological and neurological, and sort of the severity of that, kind of initial experience. And it does seem that blast injury probably produces that somewhat more. but that that dissociative sort of experience can carry through, of course, the rest of the disorder for some people, and make it challenging to treat other problems.
One of the challenges we have in the care of complex patients at the interface of neurology and psychiatry is when we do the initial assessment of someone who has experienced both psychological trauma and neurotrauma of some form, how can we differentiate TBI alone from PTSD without TBI from some kind of complex mixture of PTSD and TBI? When PTSD and TBI share some symptoms in common that don't allow us to say which one it might be, are there ways to separate that so you can say this person is predominantly suffering from PTSD and this person is suffering more from TBI?
I think it's very hard to separate them, and that's kind of where the combined approach really comes in. And I think as I've done this longer, and so I specialize in people with traumatic brain injury, and I started out seeing more severely injured patients in rehab, but my practice has shifted more to people with mild traumatic brain injury or concussion, especially people with persistent symptoms. There is this combination of both that, it's hard to distinguish them. And as I've worked with these patients, I've started to see that the psychological trauma of a brain injury, sort of there's a neurological impact, but then there's this idea of this thing that happened to me and your identity changes and sort of how you make sense of the problems you're having now as opposed to before, and is there continuity of you as a person from before and after. These dynamic situations, sort of dynamic factors are very important and often are overlooked in people with neurological injury, but the psychiatric aspects are very relevant.
I've had the privilege of helping care, as you know, for many people with these combined problems. Sometimes when the TBI component is more severe, especially, the patients refer to themselves as V1 and V2, who they were before the brain injury and who they are now, and how they try to navigate that change and deal with the change in their, not just capacities, which may be altered, but their identity, which may be altered in some way.
Yeah, it's very difficult. It's interesting that V1 and V2, I think I have not heard that terminology, but people do express that a lot. And, that feeling of sort of, this is who I was doing these things, I was this kind of person, and now I'm this person with a brain injury. And what's hard with concussion or mild TBI is that, there's this idea you should be better in 3 months, right? And so if you're not better after 3 months, you have these problems that maybe this is a you problem. Maybe this is something going on for you that is not really neurological anymore. And these patients often see a lot of different doctors who can't make sense of the real problems that they're having. And then they start to feel like maybe I am this damaged person. And so that dynamic kind of begets more symptoms. And so a lot of the work I do with these patients is helping them understand the symptoms, sort of get granular about what's really happening, and then find continuity with the person they were before. And, one interesting thing that I've started to see in that is borne out in the literature, there's a lot of ADHD sort of type symptoms in these patients, but also ADHD is a risk factor for traumatic brain injury. And so sometimes people are having symptoms that are probably related to something they had before. And if you can make that continuity and sort of help to frame the symptoms in a way that is not, I'm brain damaged now, but is more about, I had these problems and I had this stressor on top of it, you can start to kind of put the sort of identity back together and move forward.
It's extremely interesting. And I failed to mention that one of the great contributions you make to NYU Langone Health is that you're a professor in 3 departments: psychiatry, neurology, and rehab medicine, so you can really work across those boundaries. I think one of the problems in our field, we have so much specialization and even subspecialization within, say, neurology and psychiatry. We have Parkinson's doctors, we have depression specialists in psychiatry. As someone who started my medical career as a family doctor, I could never fathom the level of complexity and siloing of doctors from each other in these subspecialties. And the person is suffering across all of them and needs an integrated model for care. Perfect example you've raised is someone who starts with ADHD maybe in school and was diagnosed with ADHD. ADHD is a risk factor for persistent post-concussive symptoms after TBI, mild TBI. ADHD is also a risk factor for PTSD, and ADHD is probably a risk factor for depression. So if we're dealing with an extraordinarily complex situation where someone has a long time history dating back to childhood or early adolescence of ADHD and has experienced psychological and neurological trauma, how do we approach the treatment to deal with the profound effects on executive functioning?
Yeah, I think it's hard, and I would say it's even a little bit harder than you described because often, and I think of this because a lot of my patients, I have a lot of women in my practice with these problems, and as you know, ADHD is historically underdiagnosed in women, and so often there is not a formal diagnosis. These are women who were very high functioning and sort of maybe had these traits but worked around them, did very well in school, and sort of now are for the first time having these clear executive function and attention problems that when you go back, historically, they were there, and you can kind of find the features of ADHD. But I think this is a situation where making that diagnosis, can be very helpful and sort of just framing the symptoms and understanding this is why, you're having these problems. And again, this sort of puts you in a category of many, many people who are very talented and have sort of neurodivergent ways of thinking, as opposed to kind of thinking of yourself as kind of irreversibly damaged. And these, difficulties you're having are evidence of brain damage. In terms of treatment, I prescribe a lot of stimulants for patients with traumatic brain injuries, especially with concussion. Often, with mild traumatic brain injury in particular, they can have a lot of autonomic, sort of subtle autonomic dysfunction and other features that make them sensitive to the side effects of medication. So, we sort of have to be careful with those. But often stimulants can be very helpful. And I say to the rehab residents who I do teaching with, I say, using stimulants for someone with a traumatic brain injury is kind of a power move, because it seems scary, but actually it's very helpful for these patients a lot of the time. It can really help both with the sort of attention and concentration and also maybe impulsivity and emotional lability that comes with that as well.
That's a wonderful case example. And a treatment, the stimulant treatment, which is probably transdiagnostically helpful in some way, that if the stimulants are addressing underlying executive dysfunction that would be useful in ADHD, that would be useful for some of the chronic post-concussive symptoms, and maybe even for some of the chronic stress-related symptoms as well.
Exactly. Yeah. And I think one thing that gets sort of confusing in the literature and in clinical practice is we talk about, this idea of a post-concussive syndrome. Because a post-concussive syndrome, it's sort of, this blanket term for a lot of different symptoms that are going on or sort of, disorders, each of which might be individually treatable, but together becomes this overwhelming sort of cloud of problems this person is having. And so what we try to do with these patients is kind of, again, get granular about what's going on. So you're having attention problems, you can think about that. You're having migraines, those can be treated. You're having vertigo, maybe that's with your migraines, or sort of maybe is related to kind of inner ear problems you're having since the accident. And just kind of thinking about, what are the different problems, and things become much more manageable when you break them down in that way.
Right. We are at a point in the fields of both neurology and psychiatry in which traditional treatments, let's say in the case of psychiatry, psychotherapies and pharmacotherapies, are being complemented by the new field of interventional and neuromodulation psychiatry. And of course, that's very true of neurology also. What are your thoughts about the future of interventional psychiatry for the kinds of complex patients you care for?
Yeah, I think that there is a lot of potential there. I'm very excited about a lot of the things that are coming down the pike. I think both transcranial magnetic stimulation and transcranial direct stimulation. This is actually something that we've been using. We've used it recently in the acute rehab to help people get motor function back after injuries, and I think in the outpatient setting can be helpful with cognitive functions. This is all still experimental, but these sort of the idea is that these treatments can kind of improve neuroplasticity and sort of help with, redeveloping those pathways in conjunction with therapy and meds.
How useful do you think transcranial direct stimulation might be in the aftermath of stroke?
So actually, useful, kind of surprisingly. And it's, and I'll say, without giving specific patient information, we had a patient recently in rehab where we were using this for somebody who had a subcortical stroke. So, transcranial direct stimulation really affects the cortex, but this person had a deeper injury that we were able to, our kind of amazing TDCS team here was able to address. And what they did was pair kind of motor, sort of stimulation of motor cortex and the dorsolateral prefrontal cortex to improve kind of initiation behavior, and paired that with physical therapy. And we saw improvements after that was added. And so I think that was, sort of more severe case, and I think shows that there's potential for this, especially in milder cases.
Would you say that the underlying mechanism of change is in part creating greater neuroplasticity for new learning?
Yes, I think so. And I think that the rationale for kind of how this was done was, sort of creating more plasticity sort of at the cortical level that then kind of drove kind of neural repair and regeneration further downstream.
And it seems to me, Lindsey, as psychiatry, as neuropsychiatry, as molecular neuropharmacology and neurocircuit psychiatry matures, and our understanding of genomic influences on brain circuitry and so on develops, that the fields of neurology and psychiatry, which were once much closer together and then became siloed, should in general come together more, and that your double board program become even more relevant. What are your thoughts about that?
I couldn't agree more. I think this is so true. And, we work on the same organ and yet have different words for talking about things and different perspectives on the disorders. And I think that, as we move forward, we're getting more knowledge of what the sort of the brain basis of these disorders. I think we will be able to kind of have a closer connection with neurology. At the same time, I think the psychiatrist is always going to be extremely important in these cases because I think, as we said at the beginning, the importance of maintaining the person at the center and having a psychiatrist who sort of sees the person who has the disorder and not just the disorder itself, is really, I think, the most important thing to helping these people recover.
Thank you, and thank you for the wonderful work you're doing every day. And one thing that we're particularly proud of at NYU is we have a very deep bench in neuropsychiatry. We have I think the largest number of double board psychiatrist neurologists on our faculty of any major medical school in the country, which positions us very well to care for the patients that present enormous challenges, not just in psychiatric practice, but I think in neurological practice also, a kind of a sweet spot to fill that gap. And you've been a wonderful leader in that, both as a fantastic clinician, but also in your training role. So thank you so much for all these tremendous contributions.
Thank you so much for having me. And yes, I feel fortunate to be here at NYU.